Yeah, actually, my case is much more simple, and there was no nightmare, so my heart rate was stable throughout the procedure. Just a rare one. So, 26-year-old female was transferred to our hospital because of right-sided weakness and speech disturbance. She developed a sudden right-side weakness and slurred speech after awakening from sleep one day before transfer. She visited a nearby hospital where she was found to have acute brain infarction, and she was transferred to our hospital after initial management. On admission, she was a young lady and was thin, and the vital signs were stable. Her motor weakness recovered nearly, but she still had a right side hyporesthesia, dysarthria, dysphagia, and there was no dyspnea, no murmurs. All blood tests were normal. And here's brain MRI, which was taken in outside the hospital. Here we can see the left coronary radiator and the left putamen infarction. So MR angiogram was normal. And here we can see the echocardiogram is just abnormal shadows around the left atrium, and here we can see the posterior side to the left atrium and the dilated left pulmonary veins. And transesophageal contrast study was not significant even on Valsalva maneuver. But CT angiogram showed very abnormal venous connection between the portal vein and to the left atrium through the abnormal tortuous veins in the mediastinums. And here we can see also the multilobulated low attenuated region in the spleen, suggesting lymphangioma. And here we can see again the very dilated tortuous abnormal veins, and also the radiologists found the multiple cortical thinning in both kidneys, suggesting previous infarction or infection. So here's my question. So, are these abnormal communications between the LA and the systemic veins the cause of her stroke? Normally, the systemic vein pressure should be lower than the LA pressure. But in what condition the abnormal systemic vein pressure higher than the LA pressure? Can the Valsalva maneuver increase the abnormal vein pressure higher than the LA pressure? I was not sure at that time. Should we close them? And if we close this communication interventionally, where should I close? Just before entrance to the LA or the multiple site? How much is the risk of the thromboembolism after closure? And is there any another possible long-term problem? Anyways, I did the cardiac catheterization, and after septal puncture, I entered to the left atrium, and the LA pressure was higher than the abnormal vein pressure. So here we can see, as we expected, and arterial oxygen tension was 78 millimeter mercury at that time. But here we can see there are very abnormal venous communications, very tortuous. And here we can see the dye filling at the left atrium here. Oh, and after the confirmation of this multiple abnormal venous connections, I decided to close this communication just before entrance site to the left atrium, and I closed that with a 22 millimeter amperature vascular plug too. But unusually, the follow-up contrast echocardiography, which was taken 4 days after the procedure, showed the contrast positive even at rest. I couldn't understand what's going on. But anyway, so but the follow-up CT showed the adequate device position and the much regressed abnormal veins. And so currently, it's about 6 months past the procedure. She has no further event until now. So she's taking aspirin and clopidogrel, and I'm planning to quit the clopidogrel after the follow-up contrast echocardiography. I don't have any conclusion. It's just several remains questions. What happened to the remained portal vein to systemic vein communications? Is there any risk of thrombus progression to the normal systemic vein or portal vein? How long should I use the antiplatelet or should I use anticoagulant? Is there any risk of other liver disease, long-term hepatopulmonary syndrome or portopulmonary hypertension, because these problems are reported in portal systemic communications? Thank you for your attention.